All right, this lecture we're going to talk about fertility disorders. And when we're looking at fertility disorders, much like how I described in the male reproductive chapter, we have to evaluate both male and female to determine who or where the fertility disorder is laying. And like I said, for the male reproductive, it's actually easier to evaluate the male first. And then once they can rule out that the male is not where the fertility disorder lays, then we can go to the female as the potential fertility complication. So for the male, we're going to look at, anatomic. So do we have, anatomic structures that are off? Is it a hormonal level? Do they have a genetic defect? Is there an inflammatory disorder? Is there an immune response? Is this sexual dysfunction related to some kind of surgery that they had? Is it psychological? Is it exogenous? Where is it alcohol or drug related? And I talked about all of those in male reproductive. For female, though, once we've ruled out that the male does not have fertility issues, then we're going to look at the female. And so for females, we're going to evaluate their ovulation patterns. So when does the female ovulate? One of the common ways that they now have ovulation kits where you can actually test and find out when you do ovulate. But some women, a lot of times, will check their basal body temperature. They'll check it every morning, beginning with the first day of their period. And when they are ovulating, they will see a slight spike in their temperature, but it takes a couple months to kind of figure out where that spike occurs. We also want to check their fallopian tubes, make sure that there is no issues with the fallopian tubes, like any scar tissue. We'll check their uterine tissue to make sure we aren't dealing with endometriosis. And then we'll check other sources like their hormone levels, for example. Sorry about that. All right, so we do need to talk about reproductive life planning. Okay, so when we're talking about fertility, we also have to talk about the type of planning that individuals do. So common, and I think your book has a pretty good outline of the different types and which ones are most effective. Oral contraceptives, that is going to be one of the most utilized and one of the most effective forms of birth control out there. In fact, when we have females that are undergoing like chemotherapy, for example, we a lot of times will see where they're put on oral contraceptives because when a female is going through big doses of chemotherapy and radiation, we certainly do not want her to get pregnant because of the teratogenic effects of chemotherapy. So oral contraceptives is usually the most common one we go for because it works quickly and it gives them a very, very good protection against pregnancy. We do have contraceptive implants. Implanon is a big one that you might see where they'll have implanted contraceptive implants. And the nice thing about those is that you don't have to think about them. They're in place and you don't have to remember, like where the oral contraceptives, you have to remember to take the pill every day. The implants, you don't have to worry about that. There are depot medications. Depot medications are usually injected. So Depo-Provera is the big one I think about. Depot medications are extremely effective, but they take time to become effective. So that's why we will opt for maybe oral contraceptives over depot, especially if we're needing contraception quickly. There are contraceptive rings. The contraceptive rings, common one I think of is something called a Nuva ring. These are left in place for 3 weeks, and then on the week of menses, we'll remove the ring so that the female can have her normal menstrual cycle. There are transdermal patches. The big one I thought of was Ortho-Evra, and these you put on a patch every week for 3 weeks, and then again on the week of your menstrual cycle, the female does not wear a patch. There's also barrier methods. Condoms, there's male condoms, there's female condoms. These are proven effective against STIs. Okay, so when we get to the STI chapter, we're talking about reproductive life planning here. Condoms are, I think 97% effective in terms of that, but we're also looking at, this barrier method will protect against STIs also. Okay. Spermicides, these are like gels, foams, creams that can be utilized in addition to the barriers. You have intrauterine devices like IUDs, for example. These will usually last about 5 to 10 years. You gotta be careful with these sometimes though because they do migrate. So you just want to make sure that it is in place where it needs to be. Now, I do have to talk about these other two. There is natural family planning, and this is where people sometimes will call this the calendar method, where individuals who, depending on if they're attempting to have a family or not attempting to have a family, the calendar method shows you what the safe periods are, or what they presume are the safe periods for sexual intercourse. But again, it's not a very accurate method. But I will tell you, like, some religions, some cultures believe that this is the only acceptable form of birth control is natural family planning. And then there's also the lactational amenorrhea method, where a lot of people believe that while a female is breastfeeding, she cannot get pregnant. That is a misnomer. There is a reduction in the chance of getting pregnant when breastfeeding, but there have been several documented cases of females who immediately in that postpartum period have had sexual intercourse in that 6 weeks and become pregnant even though they were breastfeeding. So again, this is not a very reliable method of birth control either. And these are just a couple of pictures from your book. This is female condom application. So again, there are female condoms out there, and this just kind of shows you how they're applied. The diaphragm, this is one of those, like a intrauterine device, for example, but this is actually removed. It's not intrauterine, I guess it's more of a barrier method. It just blocks the entrance to the uterus, okay? But again, these things can migrate, and if it's not applied properly, it's not very effective. Now, permanent birth control, we're looking at, we already talked about vasectomy for men. For female, our version of sterilization is tubal ligation. So similar to the vasectomy, they will cut the tubes, the fallopian tubes, and ligate the ends together. This, very similar to the vasectomy, can be reversed, okay? But again, anytime you cut and suture an organ, if you try to reattach it, it doesn't always necessarily mean it's going to go back together the same way. So we call this sterilization because we do consider it a permanent form of birth control. All right, I don't want to spend a lot of time on this, but we can't talk about female fertility issues without talking about pregnancy termination. There is lots and lots of ethical issues here, and I certainly am not going to get into that debate with you guys. Please understand, with pregnancy termination, there is the therapeutic, where it was warranted for the health and safety of the mother, versus routine, which means more of it's an elective type of termination. With any type of surgical procedure, there are known risks, and the big ones that you worry about with pregnancy termination are hemorrhage, infection, and retained products of conception. So there are various methods that they can use for pregnancy termination. They can do it chemically. There is menstrual extraction. There are vacuum aspirations. You can do it with a dilatation and curettage, or a D&C. You can do a dilatation and evacuation. Some places utilize saline or urea injection directly into the uterus. Or they can just go in and do a hysterotomy, where they'll go in, cut out of the uterus. So again, lots of different methods out there for either a therapeutic or a routine pregnancy termination. Now, post-abortion care, please keep in mind when we're talking about abortion, there are things called spontaneous abortions, which is what we call a miscarriage, or there can be the therapeutic abortion, which is the elective one. Okay, so again, I'm not asking for an ethical debate here, but post-abortion care, we need to make sure that we monitor for bleeding. We want to teach our females to report any bleeding, any signs of infection. We teach her to abstain from intercourse for a while, and we definitely want her on some form of birth control so that she doesn't get pregnant in the post-abortion period. And regardless whether this was a therapeutic or a routine, grief counseling is warranted. So even when a female has an elective abortion, there's a lot of grief that goes with that, a lot of guilt that goes with that. So please make sure that we encourage her to seek out grief counseling All right. Last couple things I'm going to talk about in here is we've got benign growths. Females, they can get fibroids, they can develop polyps in that area, and then they can also get specific type of cysts. The big ones I always think are like Bartholin cysts, for example. Those can be very large cystic structures that can develop on the labia majora, for example. And then they can also develop dermoids, also known as teratomas. These can grow on the ovaries themselves, and these are pretty interesting phenomenon. These teratomas can actually, they have found like skin and teeth, bones, and hair within these cysts that grow. So we want to make sure that, we address the benign growths and make sure that they are benign and not cancerous. And I'll talk about the cancerous in a separate lecture. Last thing I'm going to talk about in this lecture is polycystic ovary syndrome, also known as PCOS. And this is resulting of an endocrine imbalance. And this endocrine imbalance where your hormones are at can lead to infertility issues, can lead to obesity, it can lead to menstrual disturbances. Females a lot of times can have like a masculinization where they'll grow facial hair, for example. It puts them at high risk for diabetes, hypertension, coronary artery disease, and polycystic ovaries is a precursor or a risk factor for endometrial cancer. So definitely some things that we need to be concerned with when we have a female diagnosed with polycystic ovaries. Many of these symptoms are due to excess in insulin in the blood due to insulin resistance. And that insulin resistance is where some of the issues come from. And it also stimulates androgens, which is what gives the female that masculine appearance sometimes that we do get with the signs and symptoms. So PCOS interventions, we're going to treat their symptoms. So we'll do antihypertensives for the hypertension, antihyperlipidemics for the coronary artery disease, oral hypoglycemics, so this will be like for your type 2 diabetes. We'll do oral contraceptives for the female hormones. We will do anti-androgen agents to help with the masculinization. You've got GnRH agonists that can be added. We want to make sure that we have a heart-healthy diet that's low in sugar, and we want to encourage exercise. And again, this a lot of times is, attributing to infertility issues. So we want to address all these polycystic ovary syndrome, and once we get these symptoms under control, then a lot of times the female is able to conceive after that.